doesn't show it for 12 flavor.
Sorry?
Mine's on 12, it's all flavor.
The problem is that you can't get it.
Yeah, I think I'll go ahead and get started, otherwise you can finish early.
Yeah.
Okay, I think we'll go ahead and get started. All right, thank you, and welcome to Cancer Center Grand Rounds. Dr. Lynch is out of town today, so he's asked me to introduce and moderate today's Grand Rounds. And so it's my distinct pleasure to introduce our first speaker today, Dr. Brenda Cartmel. Dr. Cartmel is a cancer epidemiologist who's been working on a variety of different modifiable lifestyle factors, and most recently indoor tanning. And she's worked on skin cancer for a good portion of her career. Previously, she worked at the University of Arizona, the Arizona Cancer Center, before coming to Yale, where she's been working on a variety of cancers, including skin cancer. So today, she's going to speak about tanning addiction, indoor tanning, and skin cancer. Dr. Cartmel.
Thanks. Good afternoon, everyone. And I just wanted to say thanks for the opportunity to present on my work today. So just to get straight into it, I have no conflict of interest, and just to point out that this work was funded both by an R21 grant from NCI and from the past Skin Spore grant. Today I'm going to be just briefly outlining the trends in incidence of melanoma and basal cell carcinoma, and that's the most common non-melanoma skin cancer, as I'm sure most of you know. And I'm going to be focusing on just young people. I'm then going to talk a little about indoor tanning and skin cancer, and then go on to talk about tanning addiction. So in melanoma, in adolescents and adults, that's defined as age 15 to 39, melanoma is currently the third most commonly diagnosed cancer, so a very important cancer in this age group. And it's actually the second most commonly diagnosed cancer in those in their 20s. On the right-hand side graphic, you can see the incidence rate per 100,000 by 5-year age group, and these are the current rates by women in green and men in purple. And as you would expect, the incidence rate increases with age. But one thing I'd just like to point out is that the rate in women is about double that. The incidence rate in women in this age group is about double that in men. This is the opposite that is seen in older populations, where men have much higher incidence rates than women. Recent data from Minnesota for 18 to 39-year-olds showed that over the past 4 decades, incidence rates in males increased about 4 times, and incidence rates in females actually rose 8-fold. Trends in basal cell carcinoma incidence, and again I'm going to focus on young people. There is no US state registry that includes non-melanoma skin cancer, and this is because it's such a common cancer that they just can't actually include this in the registries. But what data does exist does show increase in trends in basal cell carcinoma in young people. And this data is again available, is from Minnesota, and it shows that from the mid-1980s to the mid-2000s, basal cell carcinoma rose about 2-fold. And there was, in the paper, they report that the disproportionate increase is actually in women. So this, as we see in melanoma. I'm just going to talk a little bit now about tanning beds, because one of the hypotheses for the increase in rates in both melanoma and basal cell carcinoma in young people is the increased usage of tanning beds. Tanning beds are classified as a class 1 carcinogen by IARC, so that's really the most potent classification of carcinogen, and asbestos and tobacco are in that same category. And this classification is based on data showing tanning beds as a risk factor for melanoma. They're also classified as a Class 1 medical device by the FDA, but this is the lowest class that they have for medical devices, so the least dangerous medical devices. And in this category, such things as tongue depressors and adhesive bandages, so that's the same classification that tanning beds are in. FDA is actually looking now at reclassifying tanning beds, but nothing yet has been published about any reclassification. Tanning beds, as you may know, typically emit 5% UVB and 95% UVA. And the UVA is important because some data has shown that the UVA radiation from tanning beds is actually about 10 to 15 times higher than that of the midday sun. And we now know that UVA as well as UVB is actually carcinogenic and does cause skin cancer. A little bit about the prevalence of indoor tanning. About 10%, 30 million people, tan indoors in the US annually. And very worryingly, about 2.3 million of these are adolescents, so are under 18. In the most recent data that we have available on prevalence from a population-based study, the National Health Interview Study in 2010, published results saying that, to no surprise, indoor tanning is most prevalent in young white women. And here we have some of the data in that we can see in 18 to 21-year-old females and 22 to 25-year-old females as about 30% tanning indoors annually, slightly less in the older age of 26 to 29. And of those who do indoor tan, 58% of white females and 40% of white males are frequent indoor tanners, and this is defined as using a tanning bed 10 or more times per year. So we have high prevalence and very frequent tanning in the US, especially in white females. So we had the opportunity to look at the relationship between indoor tanning and basal cell carcinoma as part of the skin spore. Our hypothesis was that increased indoor tanning may be causing the increase in the rise in incidence of basal cell carcinoma in young people. We recruited basal cell carcinoma cases and controls with benign skin biopsies. They were all under 40 years old at diagnosis, so some of you might be glad to hear that you're still young at under 39. And we identified all cases through Yale dermatopathology. We did in-person interviews in the home and collected DNA. We had a total of 376 cases and 390 controls in this particular study, and pretty good participation rate. Just to show you our primary results with regard to indoor tanning in this population, we found a 69% increased risk for ever indoor tanning versus those who had never indoor tanned. And this risk was higher in females. We actually found a twofold increase in females, and they're much more prevalent tanners. We also calculated population attributable risk, and for those of you who might not be familiar with this term, that's the percent of basal cell carcinomas that could be prevented if individuals never tanned indoors. And for all our population, we found the population attributable risk was 27%. And when we focused just on females, we found the population attributable risk was 43%. So 43% of the BCCs in these young women could have been prevented if they had never indoor tanned. Many of you may recognise this woman here, who was called the New Jersey Tanning Mum. Last year she was arrested because she took her kindergartner into the tanning booth with her, and at least that's what she was accused of, and the child got a sunburn. And many people wondered at the time if she might be addicted to tanning, because she reported when she was being interviewed that she tanned 5 days a week, and that she tanned the maximum time of 12 minutes every time she tanned. So this is much more than is required actually just to maintain a tanned appearance. So there is actually intriguing research that supports the potential for addiction to tannin exposure. I'm just going to go over a little bit of the data now. So the biological basis for addiction can be seen in this schema here. So UV light causes DNA damage, which in turn causes stimulation of P53. This in turn upregulates the pro-opioid melanocortin gene, which results in both production of melanocytic stimulating hormone and beta endorphin. MSH goes on to ultimately result in production of melanin, which then goes to the surface of the cells to protect it against further UV damage. But it's actually this production of beta endorphin that has brought about the hypothesis that people may become addicted to tanning. This can have peripheral effects and diminish pain or irritation, but it's hypothesized it may also have central effects. So just some evidence to support the theory that tannin is an addictive behavior. Several research groups have measured beta endorphin levels in the blood and have found increased levels after indoor tanning. In a kind of an intriguing study design, study subjects were blinded to whether they were in a UV emitting tanning bed or a sham tanning bed. So that was a bed where the UV had been filtered out. And of these people, 95%, and they were tanners, 95% of them said that they preferred the UV emitting bed. So it suggests that there's something physiological going on over and above just being lying down in a nice warm bed, on a nice warm bed. There's also a study that was done where frequent and infrequent tanners were given naltrexone, which is an opioid antagonist. And in the frequent tanners, this induced withdrawal symptoms, but this was not seen in infrequent tanners. So this would be similar to people that were addicted to other subjects if they were given naltrexone. Finally, there was a small brain imaging study done that showed increased regional cerebral blood flow in brain regions associated with the experience of reward in response to the UV emitting bed. And again, this was compared to a sham bed. So again, indicating that UV may have an addictive property. So we had the opportunity, we were fortunate enough to get a study funded to actually look at the epidemiology and genetics of tannin addiction. We went back to our participants that had participated in the case control study, both the BCC cases and the controls. We limited the study to those with a history of sunbathing or indoor tanning, and we conducted an online survey with these participants. We had very good participation rate, about 81% of people completed the online survey. Excuse me, our questions were, What's the prevalence of tannin addiction? Does tannin addiction correlate with other behaviours or disorders? And we looked at several of seasonal affective disorder, depression, smoking, and alcohol. And we also were trying to answer the question of whether tannin addiction was genetically mediated. And I'm not going to be talking to this fourth point because we're just in the midst of the data analysis at the moment. We had two tools available to us that were modified from instruments that have been used to screen for alcohol abuse and for substance abuse. So the first was the modified CAGE, and CAGE stands for Cut Down, Annoyed, Guilty, and Eye Opener, and that's what the 4 questions refer to in this particular questionnaire. And as I say, it's used as an alcohol abuse screening instrument. And people were classified as tannin addicted if 2 out of 4 items were classified. 2 out of 4 items were answered yes. And the example for the cut down question is here. Have you ever tried to stop tannin but still continued? So that's, for those of you that are familiar with this questionnaire, that's how this particular question was modified. Other people had also developed a modification of the DSM-4, substance-related disorder for tannin, so we also administered that questionnaire. And in that particular questionnaire, it had 9 items, and if they answered affirmative to 3, then they were classified again as tannin addicted. Just our results here. So from our population, 44% were classified as tannin addicted.
Sure do.
Has left the conference.
44% were positive on the modified DSM. Thank you. I'm soft-spoken as it is. Background music from now on. Okay, so well, our results are very similar, very easy. On lower prevalence than we found and others found, but this is because they enrolled just any college students. They didn't have to have any tannin history, either indoor or outdoor, and it was also a multiracial group, so they got much lower rates. Following the schema of Moshe, who has worked in this field, we further classified our subjects into not tannin addicted, that's negative on both scales, tendency to tannin addiction, positive on only one scale, and tannin addicted where they were positive on both the scales, both the questionnaires. And I'm going to be presenting the results by these 3 categories. So first of all, we looked to see the number of sessions over a lifetime that people reported sunbathing or indoor tanning by the 3 tanning categories of not tannin addicted, tendency to tannin addicted, or tannin addicted. And as you would probably expect, we saw increasing rates over the categories for both sunbathing and indoor tanning. And females, again, these are young females, so under the age of 40, reported much higher in number of sessions than males who were in the green. to look at alcohol. We had a number of lifetime drinks. We saw no association between our tannin addiction categories and alcoholic drinks for males, but we did for females, where we saw a strong association with tannin addicted females reporting many more lifetime drinks than not tannin addicted females. We also looked at, assessed alcohol abuse, alcohol dependence. Again, we saw no effect for males, but we did see an association with females. So about 6% of not tannin addicted females were classified as alcohol dependent, where we had almost 23% of tannin addicted females classified as tannin dependent, and this was statistically significant. Other disorders that we looked at seasonal affective disorder, and we did see a strong association with seasonal affective disorder in both males and females. And there is also some evidence that UV exposure affects serotonin levels. So this might be the association with seasonal affective disorder. For depression, we found that males, we found a statistically or a borderline statistically significant association between depression and tannin addiction in males, but we did not see an association in females. And we also assessed exercise addiction. There is actually a questionnaire out there to measure exercise addiction. We have very small numbers, but we did actually see an association there as well. One further study that we, or analysis that we did with this data, we actually assessed how many of our cases, so our BCC cases, actually continue to tan even after diagnosis. So we restricted this to BCC cases with a history of indoor tannin. And kind of amazing to us, I think 14.6% of these patients reported to continue to indoor tan even after they were diagnosed with skin cancer, and presumably were aware of the risk of further basal cell or further skin cancers. And of those who did indoor tan following diagnosis, we found that 54% of them were frequent tanners. We did see an association between those who continued to tan and tannin addiction, with 57.7% of those who continued to tan being classified as tannin addicted versus 38.2% of those who did not indoor tan. And this was borderline statistically significant. We did have fairly small numbers in this analysis. So finally, I just wanted to point out what we know about initiation of indoor tanning. In the graph here, you can see the prevalence of indoor tanning from a nationwide study in teenagers, and we see that by 15-year-olds, almost 15% of 15-year-old females are indoor tanning. So this is a very prevalent behaviour in young people. In our particular study, the BCC case control study, we found that 50% of our female, actually of every females and males, initiated tanning at younger than 17 years of age. And if the analogy holds between tannin addiction and cigarette addiction to cigarettes or addiction to nicotine, this might indicate, because we know that people who initiate smoking at an early age are much more likely to become addicted to tobacco. So starting tanning at an early age, people may be predisposed to become addicted to tanning. We don't know this yet, but this may be the case. There is legislation, or there are laws in 2 states, California and Vermont, that do ban tanning in under 18-year-olds. Several other states currently have that legislation in front of them in this legislative session, so we'll see if more states maybe will enact that ban. So just to summarise, both melanoma and basal cell carcinoma rates are increasing in young people. Indoor tanning is now an established risk factor for both melanoma and now for basal cell carcinoma, and there are actually 2 meta-analyses that were published after our study came out, that show this association. Indoor tanning is primarily initiated in the teen years, especially in females, so perhaps making addiction more likely. Addiction to tanning may explain why some people continue to tan despite adverse consequences, as we saw in our young patients with basal cell carcinoma that continue to tan. Tanning addiction may require that new approaches to interventions are developed to reduce indoor exposure. So I just wanted to acknowledge my collaborators, and I sometimes get asked the question of where I'm from because of my accent. So I'm actually from the Lake District here in the north-west of Cumbria. Beautiful place to go, but this is a rare site because it usually rains there. It's usually not sunny. You can't go sunbathing there, so safe place. And I just wanted to finish with this one slide from David Granlund, showing that when you use a sunbed, you can select your cancer. One option he missed off here was select all, and I actually did have a friend who was an indoor tanner, and when she went to the dermatologist, she actually was diagnosed with all 3 types of cancer. So anyhow, thank you.